Afternoon, I think, to most of you, or many of you. Good morning to those from other time zones. I thought I would just, as Lisa said, talk a little bit today about milestone number 6 in our work on data aggregation in the greater Philadelphia area. I'm hearing a lot of background noise. Is that just me, or do you guys hear that as well?
I hear a lot too. I just muted myself. I'm going to remute myself. I can just have.
That's better. Okay. So just wave at me, Lisa, if you can't hear me. There we go. So Greater Philadelphia has been focused for the better part of 2018 on milestone number 6. What we have been really looking to do is support data or support practices with data and to provide them with information that we feel will be useful both for performance measurement, but also to manage their patients and their populations over time. So we spent the better part of 2017 focused on milestones 1 through 5. I indicated with check marks there that we covered those. I would say that we still have some work on a few of them, and certainly many of those activities are ongoing, and so they're not likely to just be a check the box and move on, but things that we'll obviously revisit as we progress along the 10 milestones that CMS has laid out for the payer partners. Could you go to the next slide? So what I thought I would do is, I don't know how familiar everyone is with the Greater Philadelphia region as it relates to CPC Plus. There are 215 participating practices that range from large health system owned. We have Penn, Jefferson, Temple, lots of large integrated delivery systems, and we do also have some small independent groups. They're spread out over a 5-county region that makes up the sort of greater metropolitan area of Philadelphia. The payer partners we have from the commercial end in Philadelphia include Aetna and Independence Blue Cross. They are the ones with by far the largest market share. By some measures, at least on the commercial space, between the two of them, they're in the high 80s if you add both of them up in terms of percent market share. They both have existing value-based programs. They have obviously MA and commercial members. Myself, Eric Muther, I'm the payer convener from Discern Health and have been helping to facilitate communication, have helped to basically serve as sort of the neutral party in any decision making and assist with implementation overall. And we selected Health Share Exchange, which is our regional health information exchange, as the data aggregator. They have an existing data infrastructure in place in the region here and happen to already have agreements with over 85% of the CPC Plus practices, which sort of made it a logical decision to move forward with them. I'll talk a little bit about why we ended up selecting a regional health information exchange as the data aggregator in a minute. But next slide, Lisa. So this is our vision statement. We, as I mentioned, focused on developing this right from the get-go in 2017 when we started. We really felt that it was important to have something that we could all buy into and that we felt would be broad enough to include a lot of the activity we anticipated we would focus on in the 5 years, but also something that laid out specific aims that we felt were important for both the program as well as for our region. And really the items that I think we felt were really important was sort of emphasizing this culture of collaboration. Aetna and Independence Blue Cross have been direct competitors in the region for a long time, and so we wanted to convey to providers that we were going to collaborate when it comes to this program. We recognize we'll still be competitors, but for this particular program and this effort, we all believe in primary care and improving it, and for that reason, we're going to collaborate. Next slide. So this is the CMS vision for multi-payer aggregation. I'm sure many of you have seen this diagram before. What we did is to start with this in our discussions to understand where the gaps were. We sort of did a quick gap analysis of what we have missing right now in terms of data aggregation and what practices can use for practice transformation. And so we use this as sort of the, I guess, roadmap of what we would need to put into place in order to make data aggregation work in Philly. Next slide. So the data aggregator, as I mentioned, is HealthShare Exchange. That's our regional exchange, information exchange, and we selected them because of the number of practices that had existing agreements with HealthShare Exchange, and therefore we're already in their provider database. We're already set up with direct messaging, and we're already getting ENS notifications for patients who were discharged from the hospital. HealthShare Exchange is a nonprofit, relatively new, started in May of 2012. However, they've grown very quickly and happen to overlap almost perfectly with CPC Plus, having over 6 million patients in their clinical data repository, over 10,000 physicians, and they participate not just with physicians and hospitals, but also include post-acute care, behavioral health organizations, ACOs, clinical integrated networks, as well as FQHCs. So our feeling was that because of the importance that Health Information Exchange has to being successful in the CPC Plus program, that it made sense to sort of combine both that aspect as well as the data for practices to work on. Next slide. So I mentioned this earlier, but I think it is worth highlighting that there are some very distinct advantages, some of which I would argue apply to almost whatever region you're in, and some may have been more specific to our region. And that is that as a data aggregator, the Regional Health Information Exchange does have some clear advantages. One is that you're leveraging an already existing data infrastructure. You don't need to build or contract to build new databases that will house large amounts of claims data and other data. Almost all health information exchanges, by definition, have a trusted, neutral role in the healthcare continuum to receive data from both payers and from practices. They also have a strong governance model, and this is a real, can be a real sticking point in terms of working out who has access to what data under what reason, for what reasons, and under what circumstances. And our Health Information Exchange really has a very small and distinct number of use cases and has a very robust process and set of rules in place that govern when and how folks can access data. So that was already essentially predefined for us and saved us a lot of time. The other is established relationships. As I mentioned, already had those in place. And of course, the HIE services support CPC Plus goals, such as the ENS encounter notification service, direct messaging, etc. And then the other advantage is, while our regional information exchange did not have claims data in their databases, it is a logical opportunity for us to connect claims and clinical. So this would present, for us at least, the opportunity down the road to perhaps merge some of the claims data or connect some of the claims data with clinical data, whether it's from EMRs directly or whether it's through the clinical data that is can be extracted from ADTs and CCDAs, those sorts of things. Next slide. So after we selected them, we developed our data aggregation plan, which was basically to work with HealthShare Exchange through a vendor RFP process. Through that RFP process, we selected OnPoint. OnPoint is also the organization that provides the portal for practices to use to view their Medicare data. So we saw a logical advantage in leveraging an existing vendor that has experience with that. The reports that we're going to share initially will be based on claims provided for Medicare Advantage members only. We hope and expect that that will expand to include commercial so that the practices will get a larger and larger view as we go forward. We're going to have quarterly reports that will support 8 claims-based CPC quality measures related to process utilization outcome requirements, and I'll show you those in a second. And the plan was for both Track 1 and Track 2 practices to be able to access the reports through HealthShare Exchange CPC Plus reporting portal, which they can get access through in their usual agreement with HealthShare Exchange. Next slide. So these are the 8 claims-based measures that we selected. We spent quite a bit of time discussing which of these to focus on initially. We had to exclude some because of our decision to begin with Medicare Advantage. And Medicare Advantage, for the most part, being a 65 and older population, meant that some of the measures were either less relevant or not relevant for them. We also, in Pennsylvania, have state-based super protected data laws that allow only under certain circumstances the sharing of HIV, substance abuse, and behavioral health data. And so we were not, unfortunately, this doesn't fall into an example of where that can be shared. So we had to exclude some of the claims-based measures that refer to substance abuse or behavioral health. But this was the list. So next slide. This is a quick outline of the timeline. So our goal is to have practices have available to them the portal in Q4 of 2018. We have OnPoint running all of the quality measures in the claims data sets that they get. And we're leveraging, as I mentioned earlier, HealthShare Exchange to actually provide the claims data. So the claims don't go directly to OnPoint. They actually go through HealthShare Exchange by design to, again, create kind of a common funnel for that process. We expect that, as I mentioned, we'll have quarterly updates to these, but we do recognize that, at least at the outset, this is probably not likely to be information that practices would use to fill care gaps because of the age of the data, because we have to allow for claims run out, and then there's an additional loading time. But we'd like to get that timeline down as much as we can. And our goal is to eventually be in a position where we may be able to share tentative or preliminary performance results with practices so that they can begin to look back to verify whether those gaps have been filled, and then provide final, fully adjudicated and reviewed results at a later date. Because, of course, there's no accountability tied to this. There's no payment tied to it. It's just for practices to have in order to better manage their populations. So next slide. So here's the broader timeline and plan that we have. The data aggregation and use spectrum is something I borrowed from CMS and Deloitte's application process. So I would describe, if you look at the 2017 bubble, that's kind of where Philadelphia was last year. There were some practices who weren't really using much, if any, of the reporting that the health plans offered to them in their practices. In some cases, they were getting very little in terms of data. They were just getting scorecards, but no actual claims data. Although there were also some practices, particularly those in large integrated delivery systems or in ACOs, who were getting data, claims data from payers, but it was all one-to-one. It was, payer specific, and it was also data that again, came through the involvement in the program. So our goal is in 2018 to begin the process of moving toward aggregated claims data across payers, and also to ensuring that all practices will have access to that reporting. In 2019, that's when we sort of expect and hope to begin exploring push capability. As I mentioned, providers will have to go out to a portal to view these data. And so our thinking is that if there's a way for these results to be pushed to them as opposed to pulling them to a website, that would be likely an incentive, as well as making it easier for them to look at the data. And then we also would like to look at how do we expand on those 8 measures that we're starting with. And of course, we also would love to get the opportunity to include fee-for-service Medicare data in the reports as well. Next slide. So it was very nice for Lisa to open it up by providing accolades and all these positive aspects of the progress that we've made, but I can definitely say it did not come easily. And I thought it might be of benefit for those who are just starting the journey to learn a little bit from some of our challenges and some of the barriers we had to face. So let me just review those for a second here. I can't deny it was a long contracting process, not just for the convener agreement, but also the agreements that we had to put into place, both with our data aggregator, Health Share Exchange, as well as their contracting process with OnPoint, since they are responsible for that contract, and there's no direct contract between OnPoint and Aetna or IBC. Particularly getting agreement on things like liability insurance, mutual indemnification. We're talking about pretty sensitive claims data. So as we might expect with data breaches and all that in the press, there's a lot of concern about, well, what happens if that claims data leaked out and there were allowable amounts shared or other very sensitive data that could potentially compromise this. So there were some challenges there. And then, as I mentioned, by design, we set it up so that there were separate contracts required for each party and subcontractor. So, the more contracts you have, the more complicated it gets. You need some degree of alignment, but contracts are, one-to-one, not one-to-many. The other challenge we had was around claims file format variation. This is to be expected when you're doing data aggregation, but some payers required some pre-formatting or reconfiguration, and that was an additional expense that they had to pick up. That was not, part of the shared expenses of doing data aggregation. We also found out that claims are not all reportable at the same provider level across payers. Even in our case with just 2 payers, there were differences in how Aetna and IBC organized their data regarding TIN, NPI, provider ID, et cetera. So in order to do reporting in the portal and to be able to drill down to a provider level, you need to have the database structure match. Otherwise, you can't aggregate the claims together. As I mentioned earlier, we have super protected data laws in Pennsylvania that also limit our ability to share data on drug and alcohol abuse, mental behavioral health, and HIV/AIDS. And of course, there are some different implications between payers in terms of how that affects the loading and where payers take that out. And then finally, there's varying degrees of alignment on quality measures and value-based programs. So I think I mentioned that Aetna and IBC already had value-based programs in place, which is why they applied for the CPC Plus program. While obviously we all have as a goal to look for opportunities to align those and reduce the administrative burden on practices, the fact of the matter is that they do use different measures. So trying to decide on what quality measures we do want to report back to practices is not quite as easy as we thought it might be, just because there are different measures that drive different stakeholders. And then last as well, just there was a reluctance, I guess, to modify those contracts because they have been in place and take a while to recontract. So that's sort of a short overview. I'm happy to take questions now, Lisa, or do that after the end.
Thank you very much, Eric. I know it's a lot of information to share with us, and really appreciate your thoughtfulness and organization. I think what I'd like to do is start with just one or two questions that came in from a couple of our colleagues, and then we'll move on to Mary and her team in about 5 minutes. So specifically for you, Eric, there's a question about the data governance adjustments that took place. And so this comes from our colleague Dick Schonk, who is very experienced in this space, specifically saying clinical data governance through an HIE is governed primarily by the providers. How did you include the payers in that when the claims data was added?
Yeah, that's a great question. So one of the other benefits, remember I described that there are some benefits in my view that an HIE has in terms of serving as the data aggregator. I didn't specifically list out all of the specific reasons why, in our case, HealthShare Exchange was the right entity for us in Philadelphia. But one of the reasons for that is that the governance model of our health information exchange does include payers at the table. It's not primarily run by providers. I would argue there's pretty equal representation, both at the board level as well as on all of the various committees that make up the way that the governance model was set up. So thankfully, we didn't sort of have to go back and tweak most of those. One, because at this point, we're actually sharing data that is not technically coming from the Health Information Exchange's data repository yet. That was the first reason. And then the second reason was that there were some exceptions or some uses put into the existing language around population health. And most of the reasons for us to access data and to connect clinical and claims data would be for population health reasons. So we were fortunate, again, that payers were already involved in the HIE in an active way, both financially as well as on the governance side.
Great, thank you. And then one other question really is related to governance, but about the funding structure. So the question is how this is paid for. Specifically, do the payers jointly fund the data aggregation and reporting, and whether the practices contribute to that cost as well?
Yeah, so in our case, the funding for data aggregation is split between the two payers. There is no funding requested by practices. I will say, though, that the practices do need to be members or participants of the Health Information Exchange, HealthShare, in order to get access to the data. And there is a small cost associated with joining the HIE. I believe it's around $300 a year for sort of the basic membership. The basic membership would give you access to the aggregated data reports, and you get some other limited functionality, I think use of their provider database and direct messaging, but you don't get a lot of the other services like ENS and some of the others. So again, providers aren't directly financially supporting the data aggregation effort. That's just split between the two payers. But there is a small sort of nominal cost for them to get access to the data.
Great, thank you very much. Eric, wonderful work as always, and thanks so much for sharing this with us. I think there probably will be more questions at the very end of the hour, so hopefully you'll be able to stay on with us. Yep. I'm going to stop sharing my screen for a minute and put up the next set of slides. And I also want to introduce our colleague, Mary Kemperud from Care Oregon. Mary is the Director of Network and Clinical Support for Care Oregon, which services a very large population in the state of Oregon, and is one of 17 payers there, which is sort of remarkable in terms of just the sheer size. So I do have your slides, Mary. I'm going to put them up.
Okay, thank you very much, Lisa. We appreciate the opportunity to share our story, and always interested in hearing how others are proceeding, and what Eric had to share was very informative as well. I have our project manager, Josue Aquere, with me, and he will chime in with color commentary as we go through this, because we have definitely approached this as a team effort, and we have a fairly large group that works on this on a daily, hourly basis, and so it's kind of part of our daily life. So what Lisa had asked is if we could share our kind of our journey on track 2 and where we're at, and it's been we've definitely had some challenges, forks in the road that we've approached. So I wanted to kind of I'll go through some of that and then be happy to answer any questions you might have. So Lisa, you can go to the next slide. So just wanted to give you a little background on kind of where we've come. We were, I don't have it on here either, but we were part of CPCI. Oregon was one of the regions. And so we've, you know, the whole APM, value-based payment programs, has been part of our kind of core functionality for many years so far. So we, in CPC Plus, we did, for track 1, when we started, we did lean on our existing primary care capitation incentive programs and just added on to that. So we really just added the care management fee component. We had more or less embedded the care management fee as just a component of our existing program, but had not specifically called it out as the care management fee. And then our plan with track 2 was, again, to just add on to that existing program. We also had a behavioral health integration program, which was a standalone program, but operated very similar to our primary care program. But so we're bringing those together. And then also looking at the care management fee component and the fee-for-service alternative. So one important thing, and as we've participated in the Millbank discussions and the land discussions and the CMS meetings, we are mainly a Medicaid payer. And so we, as Lisa said, we have a large population. We've got close to 300,000 members, of which probably 275 of those are Medicaid. And then we have a small Medicare plan with about 25,000 members. So it's, as we've seen and talked with others, the Medicaid world is very different than the commercial world. And so I think a lot of what we've encountered are somewhat related to the challenges of the Medicaid environment. But I mean, it all plays together, and I think it's a good kind of learning platform for all of us to as we go forward. So our eligibility for our program was for our practices was obviously the CMS designation, whether they were designated as a track 1 or track 2, they need to be recognized by our state's medical home program. And then we do have membership minimums. We did this really for the practice's benefit as well as ours. So we have currently, and we have moved these a little bit as we've kind of seen membership numbers change, but on an individual clinic basis, they have to have a minimum of 150 assigned members. And then, but we also we're in Portland in the metro area here, and we have a lot of large health systems who have their medical groups that kind of practice as a single entity with multiple clinics. So we do have a 2,000 assigned member limit or threshold for the multi-clinic systems. And that so far seems to be playing out, but I think it's an important component too. And then behavioral health, they have to, the clinics have to be able to show us what type of infrastructure they have built for the behavioral health program. And like I said, we had an existing behavioral health program already. So it was, for the most part, our major partners and the larger clinics were already participating and meet the minimum. So that hasn't been an issue for us. Okay, we can go to the next slide. So in looking at the alternative to fee-for-service component of Track 2. This was something that the Oregon payer group, and as Lisa said, I mean, at one point we were at 17, I think we're at 14 payers right now. We've had some kind of come and go, but compared, Eric was talking, they have 2 payers, we have 14. So, and a large portion of those are Medicaid payers as well, because we have the kind of a unique Medicaid structure here in Oregon. So we did work collaboratively to try and align as much as possible with, we have an active payer group with good facilitation, and we're able to get to some level of agreement on things. The one thing we agreed on in the fee-for-service reduction component was that we were going to focus on the CMS code list. And so that thinking that that would help our providers, focus on just that list of codes. We agreed that that was kind of the minimum or the standard. We know that we do have some large commercial plans involved as well, and they already had programs that may have had more codes, or and so we're plans are maybe using more codes, but that was the one thing we were able to really kind of align around. Then we're also we're looking at doing lump sum payments on a biannual basis, and then moving to a PMPM capitation component. This, and as I get to our barrier discussion, I mean, it really is a component or a result of our population, I think. So we were basing our CPCP calculations on 12-month claim history. We launched our Track 1 with the beginning of CPC Plus, and with a plan of launching Track 2 on January 1st of 2018. And we had, we put our efforts, we wanted to get the Track 1 moving, and then started to turn to Track 2, and really kind of realized quickly that we had some data constraints and issues. So that was one thing, that we, looking back, probably should have started to dig in a little bit sooner than we did in starting the Track 2 calculations. But we did end up, we launched what we called a light Track 2 on January 1st of 18, and it was everything minus the alternative fee-for-service component. So we have a Track 2 going. It just doesn't have, we haven't done the CPCP and the capitation component yet. So we have been working with our provider partners, and looking and internally with our claims and analytical teams in continuing to develop it. We were aiming for a July 1 implementation, and have just recently decided that we're going to move that to a January 1, 2019 implementation. And I will, on the next slide, you can move on, so we'll talk through kind of where and why we are where we are. So just really looking at, like I said, some of these things, I think if we would have had the opportunity to dig in a little sooner, I think we would have maybe identified some of these and been able to make some movement earlier on. But I think some of it is just kind of the world we live in. But our assignment logic, depends on identification on the claim of the correct site level information. And that, as we've worked in this, is really the kind of the crux of our issue. We have multiple groups that have a single billing NPI, yet they could have 10 or 15 site locations, and they all bill under the same billing NPI. So we have worked with our network and trying to stiffen our requirements on the claim and have them actually include a site level location or a site level NPI. And so we've had individual meetings with our key partners and some of them, the smaller providers, obviously have a unique NPI and those aren't the issues, but these are, a large portion of our population is covered in these health systems that have these unique billing IDs. So we have met individually with we've got their revenue cycle teams and their IT teams and trying to work with them in our claims in order to get the data on the claim, in order for us to get the proper assignment and attribution so that we can then ensure that the payments that they're getting are, what they deserve and we're able to reconcile everything. So that is kind of where we are right now. In some of the language that we're putting in our contracts, we are actually going to require that they use a unique site NPI on the 1500 claim in box 32 or 33. And those are the discussions that are ongoing and trying to get the information that we need in order to ensure that our attribution is accurate, which then ensures that the payment is accurate. We also had in late 2017, early 2018, a major shift in our market here in the Portland metro area. And we had one of the major Medicaid plans exited the market very suddenly in like a six-week time frame, and we took on 80,000 new members. And so right when we were looking at, trying to implement a capitation component with our providers, their membership just went, kind of chaotic on us. So we are just now kind of coming out of that with the membership flux. And so we really, with the amount of dollars that are tied to the payments, it's just, we had to be mindful, and we wanted to, again, make sure that we were getting the providers the right member assignment and attribution, and that we were, the money was flowing properly. With these 80,000 lives that we added, we did get a claims dump, but it's not something that was readily available for us to use in our analytical tools and in the calculation of the CPCP. So that's been, an added challenge, and part of the rationale behind us moving to a January 1, 2019. It's going to allow us to have some claim history on these members and to be able to make more accurate financial estimates for our providers. And then I think, and kind of just what I had mentioned with the Medicaid membership, I think it's a different population than the commercial world. We have routine on a monthly basis. We have individuals who do lose coverage, and then, may come back up and beyond in 2 months. And so that just kind of coupled with the reassignment of where they move between PCPs a little bit more fluidly at times. And so, again, it speaks to the need for us to have that very specific claim information so that we believe we have some, solid ground to be paying the providers from. So we can move on to the next slide. So we are moving forward, and we are, we're excited to get this done, and really hoping to, and we've got good engagement with our provider partners, and we're just kind of helping them process through things. But what we want to do is be able to work with them and start testing and ensuring that we've got the right information on the claims. So hoping to do that in the October and November timeframe, and be able to actually do some testing and make sure that everybody, is understands and we all kind of have a solid agreement on the data. And then we also are looking to do some more analysis around the fee-for-service, the CPCP component of the fee and adjusting the fee-for-service. We've got the claims data for our new population. We are also looking at some kind of review process to ensure that we have, again, with the fluid Medicaid membership, we're thinking that we need to have some interim review processes to make some adjustments for membership moves and just making sure that the payments are representative for the services being provided. And looking at doing an annual adjustment to the how we fund the program as well. And then membership change is another component as well, and just wanting to make sure that we have a mechanism to look when something triggers if there's been a significant move in membership or eligibility. So I think, and hopefully I don't know, do you have anything else to add? So I think that's really, kind of where we're at. And like I said, we're excited to continue forward. And we are, trying to work with our provider partners and make sure that we are able to get this implemented successfully by January of 2019.
Mary, thank you so much. That was really great. And I'd like to open it up for questions. Some of you, I may have muted you just because of some ambient noise, and you can either unmute yourself or send me a quick chat message and I will make sure to unmute you. Mary, I had two questions that I just wanted to start with. One is, as you go through this process and you're sort of reacting a lot, obviously, to the environment in which you find yourself, especially having just a huge surge in membership, which obviously had to have a gigantic impact on any planning you were doing. But, there was for a time, the land pack and some support for working through some of the track 2 planning and implementation, and what kind of conversations you had either with specifically people in the land or with our colleagues at CMS in Baltimore, specifically with Rave's team, if there was what kind of ongoing discussions you had as you tried to work through this.
Yeah, we definitely, have been participating in the land pack and, have use that kind of as a sounding board to try and get some specific, other information and try and learn from others about the attribution concerns. But like I said earlier, I think one of the big things is the fact that we are, almost purely a Medicaid plan. I think that we do face some different challenges in that space than other payers. And so I think it's definitely a bigger concern. We've kept in touch with CMS as we've kind of worked through this. I think, again, I think it's kind of, we're in a little bit unique space in some of this. Our Oregon payer group has been really an effective sounding board. We meet regularly, and even in the Oregon environment, there's still still a lot of differences in a lot of these elements. And I think Eric had mentioned too about even just how the claims are ingested and then reported back out. It's different by payer. So all of those intricacies really add to the complexity, but I think having the access to all those different resources and partners has been very helpful. And I think it's the way we're going to be able to move this forward, in Oregon and across the country too. So I think we're doing the right thing. I'm sure we're going to encounter some more as we move forward.
Thanks, Mary. So any questions from the crowd? Let me just make sure I'm going to unmute everybody.
Sure. I think You know, I do has and I'm
Is this Ben? Is that you asking a question?
the rural areas of Maryland, given I was raised in a rural area, and I see, you know, sort of the challenges that we've let this percolate, you know, not through our action, but the enormous political challenges on trying to get anything done with you know, everyone is facing this reality of limited good, where Joe wins and I lose. That it's a daunting political process. That I definitely agree, and you know, trying to get everyone at the table to back off or to push forward, so to get momentum all in the same direction is really important.
I think we may be listening in on a conversation. Are there any questions? Eric, maybe you have something to comment on the work we heard from?
What you know, we as civil servants are supposed to.
Sorry, Lisa, what was your question?
My question is if you had any questions or comments on, obviously a very different environment than what you've been working with in Philadelphia, but anything that you wanted to add or say about what Mary had presented to us in terms of working with this large group of patients and specifically in the Medicaid field. It's an interesting contrast.
Yes, I mean, there are a lot of interesting thoughts that I have about how it compares and contrasts. So we do not have Medicaid actively participating in our region. Certainly, because the Greater Philadelphia area does have a fairly high Medicaid population, it would benefit if we were to be able to at some point down the road include them in on this in terms of getting practice attention and including them as a population in the overall transformation. As she pointed out as well, certainly 2 is very different than 14. Although I would argue all you need is 2 just to begin the complexity journey. It just gets more complex with more numbers. But it certainly, I think the benefit of leveraging, for example, a distinct data aggregator is that you can also get some agreement on common templates and then have a discussion about how much of the configuration and the adjustments that payers may need to make to match that common template, should be borne by them themselves or should be shared. And that may just depend on how much work is involved in getting the data prepared to be, used in that template. But that has another benefit of essentially, if everyone has to do some work, it feels a little bit more equal than having some payers not needing to do anything and other payers needing to do a lot of reconfiguration and a lot of adjustments. The other is the comment just about the relationship between providers and practices, and that's another key difference that I've seen. And even I mentioned the quality measures. So really quick side note, we for our regional learning session, we decided that we felt like it might be interesting to aggregate some summary data, so not claim level data, but the results of claims from numerators and denominators, bring them together from the 2 plans, and then share them back with the practices at that learning session. And even just doing that exercise, we discovered that the 2 payers have different measures in place for poor A1C control. One used 8, one used 9, and so that limited our ability to aggregate the data without confounding the results, because certainly while they're close, 8 and 9 are different. And so that was a little kind of microcosm or a little, prototypical example of the complexity that is in front of us in terms of aligning measures, aligning programs, and aligning data. It was very interesting for me to hear Mary's. One thing I will say about Philadelphia was that we had the benefit of having an extremely high number of practices essentially already have a track 1 or track 2 like arrangement in place with the payers because of the penetration of value-based arrangements in Philadelphia.
Eric, this is Bonnie Sunday. You mentioned that you have a portal for the providers to go to for the CPC Plus metrics. Do you foresee in the future that this portal would be expanded to all metrics and all, I mean, the holy grail basically of combining claims and clinical and putting it in one provider dashboard that's payer agnostic? Do you think that it's feasible to get to that point, or are the payers not real interested in giving up their own population health tools that they now have provider facing?
That's a hard question to answer. I certainly have heard from both payers that they have agreement on sort of a shared vision of having a one-stop shop. How we get there and when we get there, I think, is where the rubber hits the road and there starts to, uncover some different opinions on that. The other thing that, of course, will impact that, Bonnie, for us is if and when we get Medicare fee-for-service data, the question I think will come up at some point is why should practices sort of not go into the portal that, or why should practices feel like they need to go into two portals? If they can get, the Medicare data on the Deloitte or the OnPoint portal that's currently being provided right now to them, it may be challenging for us to get them to go to yet another portal to see the aggregated payer data, even if it now includes Medicare. Now, we're hoping that the attractiveness of having a single report with Medicare and the commercial payers all in one will be enough of an attraction. But if it's not, that's why we're also looking into this push functionality, where rather than trying to get them to come to a portal, maybe we can push it to them so they can look at it that way. But it's a great question.
Thank you. Any further questions for either Mary or for Eric? We're just about 2 minutes before the hour. I want to once again thank both of you for doing just terrific presentations and sharing your experience and expertise with the group. I'll ask you offline if it's okay to be able to share these slides, and hopefully that will be the case, or some version of them. At the very least, this has been recorded, and so any of your colleagues who did not have a chance to call in today will be able to listen to the excellent presentations. I would like to make one request. I think all of you heard from me yesterday when I sent out an email. As everyone knows, there was the request for information about direct provider contracting, where the deadline for submission of comments was last Friday. I'm hoping to collect this information just to get a sense of where people have landed on this topic. So please, if you haven't had a chance, send me either your organizations or your personal comments that you may have submitted to our colleagues at CMS, and we'll be collating that, and if it's okay to share them, then I think we can learn a great deal from each other. So once again, thanks everybody for participating in this. Next month we have another really excellent webinar scheduled. Our colleagues from the Institute for Healthcare Improvement and the Commonwealth Fund will be talking about a specific project they've been working on that we at Millbank are now contributing to, called the Playbook, and specifically looking at high-cost, high-needs populations and how primary care can work to support them better. So once again, thanks everybody. Terrific conversation today, and I look forward to seeing you next month. Bye-bye.